Hello, everyone. Welcome to the second day of the NUGoKidney Symposium. It's my special pleasure to introduce our guest speaker for today's talk, Dr. Katherine Tuttle. Dr. Tuttle is the Executive Director for Research at Providence Healthcare, co-PI of the Institute of Translational Health Sciences and Professor of Medicine at University of Washington. Dr. Tuttle earned her MD degree and completed her residency in internal medicine here at Northwestern University in Chicago, Illinois. So she was a fellow in Metabolism and Endocrinology at Washington University in St. Louis. And she completed her Nephrology Fellowship at University of Texas in San Antonio. Dr. Tuttle's major research focuses in diabetes and chronic kidney disease. She has published over 250 original articles and served as associate editor for the Clinical Journal of the American Society of Nephrology and the American Journal of Kidney Disease. Dr. Tuttle has received many honors and awards, including the Medal Excellence from the American Association of Kidney Patients, the Garab-Technonian Award from the National Kidney Foundation, the YWCA Woman of Achievement Award in Science, and 2 outstanding clinical faculty awards at University of Washington. Dr. Tuttle served on the board of directors for the Kidney Health Initiative and has chaired working groups and committees for organizations, including the NIDDK, NKF, FASN, the International Society of Nephrology, and the American Diabetes Association. Specifically, she's the chair for the Diabetic Kidney Disease Collaborative Effort at the American Society of Nephrology and has been involved in writing guidelines for KDIGO, KDOKI, ADA. So it's, again, my pleasure to have Dr. Tuttle in our symposium, and I will pause here and let her start.
Well, thank you very much for your kind introduction, and it's truly a pleasure to return to my homeland of Northwestern to give this presentation. And I'm really excited that we can now talk about kidney health and diabetes. It really is a transformative time. Here are my disclosures. So our objectives today will be to first understand the scale and risks of diabetes and chronic kidney disease, and to recognize that SGLT2 inhibitors and a non-steroidal mineralocorticoid antagonist are new standards of care. We'll also discuss GLP-1 receptor agonists for cardiovascular risk reduction and preservation of kidney function, and then comprehend team care as a strategy to implement personalized therapies for heart and kidney protection. So first off, I'd like to start with a little bit of terminology that often gets confused. And that is, what is diabetic kidney disease versus diabetic nephropathy? So diabetic kidney disease is really a clinical diagnosis based on albuminuria, low eGFR, or both in a person with diabetes. So by and large, DKD means CKD and diabetes, but it is not a specific pathological phenotype or diagnosis. Diabetic nephropathy has been traditionally used to specify classic glomerular lesions attributed to diabetes that we see on kidney biopsy. So that would be glomerular basement membrane thickening, mesangial expansion and nodules, podocyte loss, and endothelial disruption. And because we rarely have kidney biopsies, when we talk about the trials, we're really going to be talking about the more general CKD and diabetes based on clinical criteria. This is actually important because we are moving toward doing many more biopsies, especially in people with diabetes, because there's great heterogeneity in phenotypes. And when we eventually move to more precision phenotyping, we will be able to apply drugs more specifically to individual patients. But today, the trials we'll be talking about are really based on garden variety CKD and diabetes, or DKD, and I may use those terms interchangeably depending on context. So first off, let's talk about the problem with diabetes. This is where it all starts. So despite what we know about diabetes prevention, unfortunately, this is really not translated in a meaningful way into communities. There are currently 537 million people worldwide with diabetes. And as recently as December of 2021, the International Diabetes Federation projected that by 2045, this number will grow to 783 million. And in regions encompassed within this ellipse, over that time period, there will be more than a 50% increase in all regions, and in some areas, such as sub-Saharan Africa, more than 134% increase. So while diabetes prevention really remains the holy grail, the truth is for the foreseeable future, and truthfully all of our lifetimes, we will be seeing more and more people with diabetes, which means more and more people with diabetic complications. Kidney disease is one of the most serious matters. It is still very common, occurring in about 30% of people with type 1 and 40% of those with type 2 even today. Diabetes is now the most common cause of chronic kidney disease and kidney failure worldwide. And in the US, actually, our patients treated for end-stage kidney disease by dialysis or kidney transplant have an even higher prevalence, 66 to 86%, depending on age and race or ethnicity. And the reason for this is diabetes is common and may occur with other forms of kidney disease. For example, a person could have diabetes and have polycystic kidney disease. But oftentimes, especially in the transplant population, we're burdened with, or the patients are burdened with post-transplant diabetes due to medications such as glucocorticoid inhibitors and calcineurin inhibitors. And so in nephrology, we actually proportionally treat more patients with diabetes than in endocrinology. And I attend on both services. And I say that to people to give you a hint of how staggering this problem is within the nephrology community. And even from the standpoint of cardiovascular risk in diabetes, what we found many years ago, looking at the NHANES data set, is almost all the excess cardiovascular risk in diabetes is in those who have albuminuria, low GFR, or both. So even if we want to identify people with diabetes for high cardiovascular risk and risk reduction strategies, this is a particularly important group to identify. Speaking of risks, what are the risks of developing kidney disease and diabetes? Well, truthfully, even though our focus in nephrology has traditionally been on progression to end-stage kidney disease or kidney failure, the truth is that only 10% survive to this endpoint. And that's not because they're staying healthy or doing well, it's because of the striking mortality. And I want to point out, this is before kidney failure. These are bodies littered on the road to kidney failure. 90% will die, and half of them are cardiovascular causes, both atherosclerotic CVD and heart failure, which I will address. And the next leading cause are infections. Before the pandemic, it was mostly pneumonia and sepsis. And one can only imagine what COVID has done in terms of infection-related deaths, because we know that these individuals are not only more susceptible to developing COVID-19, but more likely to have severe complications. And early signals are for very high mortality rates. So it remains to be seen the impact this will have in the current time period. The KDIGO guidelines for diabetes and CKD were just published about 16 months ago, but because this field is moving so very quickly, there will be a 2022 update, which is currently under review, but I am going to give you a sneak peek of some of the changes, and this was actually presented at the International Society of Nephrology meeting, so it is considered public information. I think most of you may be familiar with this KDIGO heat map, but it's really been modified now to be more action-oriented. So you'll see that across the risk categories from green to yellow to orange, we now have 2 shades of red, and we have action items from screen to treat and refer. And notice that all the red boxes mean tag you're it in nephrology. It says treat and refer. The reason is that these are very high-risk patients, and we now have things we can do about it. Perhaps in the question and answer, we can discuss the workforce issue, but I would posit that this is making nephrology even more and more relevant in medicine in general. And I think that's really important that we come out of our silo and refocus our efforts on maintaining health as opposed to treatment of kidney failure. This is the updated guideline that will be published very soon. And I would also point out that the other thing that we did with the update was worked simultaneously with the American Diabetes Association Standards of Care Committee. Some of us served on both committees, so that was convenient. So that basically one of the things that needed to be done, and we've at least accomplished between the American Diabetes Association and KDIGO, is alignment of guidelines. So I'm going to show you the guidelines, and then I'll show you at least selected pieces of information in the limited time we have that back up these recommendations. The real changes here from the original guideline published 16 months ago are shown in the ellipse. We now have SGLT2 inhibitors as first-line therapy with or without metformin. In the prior guidelines, metformin was always listed as a required first-line therapy in people with type 2 diabetes if they had an adequate GFR. That has been removed. It's recommended if appropriate, but not necessary, particularly in people who have CKD or who are high risk of cardiovascular disease. These now can be used as first-line agents for glucose lowering and or organ protection. The next line agents now that have come directly into the guideline are GLP-1 receptor agonists, which were there before for glycemic control, but they've now been added as a recommended therapy for patients with persistent albuminuria to reduce cardiovascular risk and risk of GFR decline. And the non-steroidal MRA finerenone has been added as indicated for patients with persistent albuminuria who have a normal potassium, with the goal of reducing cardiovascular risk, including heart failure and atherosclerotic CVD, as well as progression to kidney failure. So let's back up and talk about where this all started. Well, it really started with the cardiovascular outcome trials of the SGLT2 inhibitors. And in 2015, when these trials were published, they really stunned the world because the design of these trials was based on a mandate from the US FDA in 2008 that new drugs for glucose lowering were required to have a clinical trial to prove cardiovascular safety after approval for marketing. And it was required so that they could stay on the market. And that was because older drugs, rosiglitazone in particular, had been associated with an increased risk of cardiovascular events. And the idea was to protect the public by a safety study. But it turned out that it really was the gift that kept on giving, because not only were the agents safe, they were remarkably effective for reducing cardiovascular risk, and in particular heart failure, which was an area that had really lagged the ASCVD field in terms of risk reduction. And the major secondary endpoints were related to kidney disease. And across the board, these agents decrease onset and progression to macroalbuminuria, GFR decline, and kidney failure. And in this very high-risk group of patients with type 2 diabetes and CKD, both the cardiovascular benefits and the kidney disease benefits were preserved. So even patients with low GFR had lower risk of these adverse outcomes. Since that time, obviously the field has just exploded, and we don't have time to go through all of the trials. So what I've done here is summarize this meta-analysis, focusing on the kidney failure and heart failure outcomes in people with and without diabetes now from all of these trials that have literally pummeled us over the past 3 years. It's really been a remarkably exciting time. Never in the field of nephrology have we had so many clinical trials, and all of them positive. The long and short of it is trials were done for heart failure and kidney disease after the cardiovascular outcome trials. They were conducted in people with and without diabetes. And what you can see is for the kidney disease outcomes, the three trials that included non-diabetic patients, 2 heart failure trials, and DAPA-CKD, nearly a 50% reduction in some measure of substantial GFR decline. Depending on the trial, it was 40 to 57% GFR decline, dialysis, transplant, or kidney death. And then in the diabetic population, you can see again this parade of studies and a similar hazards ratio of 0.63. This is not different statistically than the non-diabetic patients, but what we can say and what's important is even in people without diabetes, the risk is reduced at least as much, and by nearly half. And then when we look at the cardiovascular outcome, in particular heart failure or cardiovascular death, we also see substantial risk reductions, more in the range of 25% in the non-diabetic and diabetic trials. The other important thing to recognize is that these benefits on kidney disease outcomes are present across a range of albuminuria and GFR. This is just showing the first 3 cardiovascular outcome trials where most patients had preserved GFR, in contrast to Credence, the first kidney disease trial, where more than half had low GFR. By design, Credence, all Credence patients had macroalbuminuria, but many patients in the CV outcome trials did not. And here's what's really important is even the patients without albuminuria and preserved GFR still had the benefits on kidney and cardiovascular outcomes, which has really led us to extend the use of these agents now even more upstream to kidney disease prevention. The DAPA-CKD trial I want to point out in particular because of the effect on all-cause mortality. So this was the second kidney disease trial, and it enrolled people with a GFR as low as 25 and a urine albumin to creatinine ratio as low as 200 milligram per gram, so a little below the macroalbuminuric range. And about a third of the patients did not have diabetes. That was simply DAPA 10 milligrams versus placebo on the background of standard of care, which was an ACE inhibitor or an ARB. And here's the primary endpoint, 50% decline in GFR, end-stage kidney disease, kidney or cardiovascular death reduced by 40%. But this is the first time ever in nephrology for any treatment for kidney disease that we have had a drug with a benefit on all-cause mortality, which is the ultimate endpoint for any condition. You can see the hazards ratio is 0.69, a 31% reduction in risk of death on top of standard of care. This is really unprecedented. Remember the remarkable death rates I showed you at the beginning. So this is a real win because these agents not only preserve lives, but among the living, reduce risks of heart failure and kidney failure substantially. So this is what we've been waiting for, preservation of life, and among the living, preservation of function. Because of these remarkable results, dapagliflozin was the first drug ever for kidney disease granted fast track breakthrough priority approval by the US FDA. It was approved almost a year ago for this indication. And with regard to the all-cause mortality, which to me, again, is the most important endpoint because you have to be alive for any of the other stuff to happen. If you look at the diagnoses here, irrespective of whether they had so-called diabetic nephropathy or other forms of non-diabetic CKD, the effect on mortality still held. So these drugs not only reduce mortality in patients with diabetes and CKD, but across the board in patients with CKD who are probably representative of most people we're seeing in practice. So how does the magic happen? Well, you know, we have the marvelous serendipity that these drugs were sort of accidentally discovered. And so we're actually retrofitting the science to understand mechanisms. And that is a very active area of investigation. But one mechanism that we know is important is a hemodynamic mechanism. And that's important to discuss because that's clinically targetable. The first clues came from the GFR trajectories. Virtually all those trials have published them, but I've selected 2 representative ones. This is from the EMPA-REG trial in patients from the cardiovascular outcomes trial with relatively preserved GFR, contrasted with Credence, a group selected for CKD with substantially lower GFR, 76 baseline in EMPA-REG and 56 mean baseline in Credence. But irrespective of baseline GFR, you see this abrupt decline in GFR followed by stabilization over time. And note that it's dose independent. Here we show 2 doses of empagliflozin. Same exact pattern seen with canagliflozin in people with lower GFR. It was as if they read Brenner and Rector. This is the classic signature of reducing glomerular hyperfiltration. It occurs quickly with onset of taking the medicine, and then over time, stabilization that is not seen in people who don't receive the drug. So I'm going to take you down a trip down memory lane since I'm back at Northwestern and I first learned renal physiology from some of my professors there. I will take you down a little bit of memory lane, because I think understanding mechanisms really is critical to proper therapeutic application for both safety and efficacy. So if we go back to what is the state, untreated state in diabetes, what we have is glomerular hyperfiltration. And this is because of a relatively dilated inflowing or afferent arteriole and a relatively constricted outflowing or efferent arteriole, so that the glomerulus is engorged and under very high pressure. There's also increased filtration of glucose into Bowman's capsule and then transferred into the proximal convoluted tubule. And at this site, SGLT2 transporters are upregulated both in number and function. This is believed to be an adaptive mechanism to reclaim glucose, but in fact, it's maladaptive because it also raises glucose. And there's decreased distal delivery of solutes, not only glucose, but also sodium and chloride, because this is a sodium requiring process. At the macula densa, these specialized epithelial cells, when they reclaim glucose, it's an ATPase requiring process that generates adenosine, which is not an innocent or silent metabolic waste product. It's actually a very active paracrine factor that moves next door in a paracrine fashion to constrict the inflowing artery. So we have relatively unbridled hyperfiltration because we've lost the normal vasoconstriction. When we give an SGLT2 inhibitor and block glucose reuptake at this segment, we lower blood glucose, which was the original idea of applying these agents therapeutically, because we're not reabsorbing as much glucose, but we're increasing distal delivery of solutes, including sodium chloride, and we reactivate this process that activates vasoconstriction. This is called tubuloglomerular feedback. But this action at the level of the kidney has many actions that carry over into systemic effects. So this is a summary of the actions at the level of the kidney. And importantly, the lower tubular workload may help us understand another important side effect of these agents, which is a good side effect, which is lower risk of acute kidney injury as well. So because of these effects, we have less plasma volume, less sympathetic nervous system activation. We actually have increased erythropoietin because there's a relative ischemia in the medullary thick ascending limb, which activates erythropoietin production. And of course, lower blood glucose, body weight, and an increase in free fatty acids because these drugs actually raise glucagon. This leads to a mild ketosis, which in the mild form is actually good because beta hydroxybutyrate is a preferred myocardial fuel. There's increased red cell mass and oxygen delivery to the heart. There's lower blood pressure, less LV wall stress. Some have posited that sodium hydrogen exchanger 3 in the myocardium may be inhibited by these drugs, although it's debatable whether that off-target effect exists or not, but that's under active study. And all of these changes culminate in less oxidative stress. So at least now, this is how we've conceptualized that this kidney-related mechanism certainly protects the kidney in terms of reducing glomerular hypertension, but has far-reaching systemic effects that then in turn provide profound cardiovascular protection as well. So I mentioned reduced tubular workload. One of the posited potential risks that people feared is that these drugs could cause acute kidney injury. Exactly the opposite is true. This is a meta-analysis of 3 of the CV outcome trials with credence, and you see a 25% risk reduction in AKI. So it's actually protective against AKI. This is a paper that's currently in press looking at a pooled analysis of the empagliflozin trials and safety signals. And again, not only did we find the drugs were safe, but for 2 important adverse events, formation of edema or development of hyperkalemia, empagliflozin actually significantly reduces these risks. So this is most likely due to the diuretic effect on edema. But the hyperkalemia reduction is really, really valuable when we start thinking about combination therapies, especially drugs that may raise potassium, whether they're ACEs or ARBs or a mineralocorticoid antagonist, which I'll address in just a little bit. But next, let's pivot toward the other big class of glucose-lowering agents. Soon after the SGLT2 inhibitor trials came out, we saw the parade of the GLP-1 receptor cardiovascular outcome trials. And again, across the board, not only were they safe, they were highly efficacious, but this time the prominent effect was on reducing atherosclerotic CVD with a neutral effect on heart failure. And 2 agents in the class have also been shown to reduce cardiovascular death. And with regard to the secondary kidney outcomes across the class, they reduce albuminuria, GFR decline from early to very late stage CKD. So these have been used in people with GFRs as low as 15 in contrast to the SGLT2 inhibitors. And the CKD and CVD benefits are present, again, even in patients with pre-existing CKD. So just to summarize the cardiovascular trials now of the GLP-1 receptor agonists, again, when we look at the risk of atherosclerotic CVD, we see overall a risk reduction of about 13%, which in that field where there are already so many protective agents is considered highly clinically meaningful. But note that even in low GFR, we still see that same cardiovascular protection, irrespective of baseline kidney function. And with regard to the kidney disease outcomes, again, we see a significant reduction in outcomes. And if we only look at GFR outcomes, it just misses statistical significance. But I would point out to you that in the cardiovascular outcome trials, where people are selected for cardiovascular disease, and as I showed earlier, mostly don't have kidney disease at baseline, and albuminuria outcome is going to be more evident within the early time frame of trials because GFR decline would occur later in people who have relatively preserved kidney function at baseline. So what do we know about people with lower kidney function? Well, this is from the Award 7 trial that was a glucose lowering trial comparing dulaglutide versus insulin glargine. So importantly, equivalent glycemic control here. So the changes are independent of glucose. You see that in this group of patients that came in with a baseline GFR mean 35, that you see the progressive decline over 1 year with insulin that stabilized by either low or high dose dulaglutide. This is just a bar graph showing GFR change at 26 and 52 weeks. And there's a highly significant difference in risk of GFR decline. This has now been reproduced for semaglutide, looking at pooled analyses from 2 big cardiovascular outcomes trials, SUSTAIN 6 and PIONEER 6. And you can see this is GFR decline. You can see an estimated treatment difference over 1 year of 0.6 overall. But note again, in the patients with low GFR, there's even a more profound effect to reduce rate of GFR decline. The estimated treatment difference here is 1.07 between standard of care or placebo versus semaglutide. I will also point out to you that work from the CKD Prognosis Consortium has shown that any treatment that makes a difference between the intervention and the control group of greater than 0.75 mil per minute per 1.73 meters squared over 1 year is highly predictive of a treatment effect to prevent kidney failure. So the point of all that is that this is in the range that we would project would be highly relevant in terms of preventing a true clinical outcome of kidney failure. The effect is also present in people with higher GFR, but much more evident in those with low GFR. This is a pre-specified but exploratory analysis back to Award 7, where we actually did look at those endpoints, 40% GFR decline or kidney failure requiring dialysis or transplant. You can see overall there was more than a 50% reduction in event rate between insulin and the highest dose dula group. And in the macroalbuminuric subgroup, which was about 50% of the patients, and these are the people who are highest risk to progress to one of these endpoints within a 1 year time frame. You see the hazards ratio is 0.25. This is the largest risk reduction yet we've seen, a 75% risk reduction in progression to endpoints. Now, admittedly, this is an exploratory analysis, so it has to be viewed with caution, but it certainly supports the hypothesis that these are likely to be kidney protective in clinically meaningful ways. How might the magic be happening here? We think really quite differently. This is from one of our reviews in Nature Reviews Nephrology, where we summarize the available data, but it really comes down to the GLP-1 receptor is present on cells in the kidney, but not only intrinsic cells, but most importantly, I think, are the infiltrating immune cells, macrophages and T lymphocytes that are present in the diabetic kidney. And these immune cells, when GLP-1 binds them, they activate a number of processes that block production of reactive oxygen species and signaling to inflammation, fibrosis, and apoptosis, which may be the apoptosis signaling may be most important for the intrinsic kidney cells. So they're really quite different. These, we believe, had a direct anti-inflammatory effect. And if you look at preclinical models, what we see in the animals is that there's restoration of podocytes, the mesangial expansion is less, and there's much less tubulointerstitial inflammation and fibrosis. So we also view from the standpoint of therapeutic development, this is very handy because this would likely be a complementary therapy, for example, to an SGLT2 inhibitor, although yet to be tested in trials. That said, the available data from the secondary outcomes in glycemic trials and cardiovascular outcome trials, along with the preclinical data, has rolled up to now a major clinical trial. At the end, I think we finally enrolled 3,500 patients in FLOW. It's fully enrolled. Classic DKD population, now testing semaglutide for hard kidney outcomes. And despite the pandemic, we've done a good job of retaining people on the trial. And we look forward to the results of this to find out in a more definitive way whether these agents will really deliver on top of the standard of care for true kidney protection. I'm only going to mention this briefly. With all the excitement, we do have to consider that there are risks of these therapies and there are risk mitigation strategies that are required. I mainly put this in so that if you have the slides, you can take a look at it. But the most common one with SGLT2 inhibitors are genital mycotic infections, but this can be mitigated by advice regarding daily hygiene. Some studies have shown more than a 50% reduction in this side effect by just advice regarding hygiene. Volume depletion, because remember, these drugs do cause an osmotic diuresis, so patients at risk for hypovolemia might benefit from a diuretic dose reduction. And then the other rare but serious side effect is euglycemic ketoacidosis. However, there were no cases in the dapagliflozin treated group and DAPA-CKD, and I think only 11 in 3,000 patients in Credence. So while it is rare, we still need to be cautious, and that really involves educating patients on early recognition and the so-called stop DKA protocol during sick days, stopping the medicine, testing for ketones, and maintaining fluid carbohydrate intake and at least some insulin and insulin users. Amputation was only seen in the Canvas program. It's not been seen in any other trials, but it's a reminder that good kidney and diabetes care includes foot examination, teaching patients about self-examination, and then healthcare professionals just simply looking at the feet and checking pulses at their visits. Hypoglycemia is not a direct side effect of these agents, but when given with insulin or insulin secretagogues, it can occur. So that's important in terms of perhaps adjusting doses of those agents. But we do recommend that in insulin users, at least low-dose insulin is kept on board because that's our best defense against ketoacidosis. The GLP-1s in some ways, I would argue, are a little easier to use. The main side effect is gastrointestinal, but with low doses, starting low and progressing slow up to the full dose, these symptoms often abate. And then with regard to hypoglycemia, again, it's similar to the SGLT2s adjusting background anti-hyperglycemic agents, but these agents in themselves are not hypoglycemia producing. However, stumbling on the glucose lowering agents by accident, is probably not something that we can count on going forward. It reminds me of this Jackson Pollock painting, which is lovely in its own way, but rather non-directional. So it's been lovely, but non-directional. So how do we get a little more directional? And I would say that already we're moving in that direction. And one example of that is the development of the new mineralocorticoid antagonist class. And even though we learned about homeostatic regulation of electrolyte transport in the cortical collecting duct as the main role of activation of this receptor, it turns out that mineralocorticoid receptors are present on a number of other cells. And again, particularly inflammatory cells that may invade the kidney, such as macrophages, but also myofibroblasts, which are epithelial cells that have a phenotype transformation and move into the interstitium where they promote inflammation and fibrosis. Podocytes also contain them, as do mesangial cells. And it turns out when the mineralocorticoid receptor is activated in the immune cells and the non-epithelial cells, they activate this, the mineralocorticoid receptor transits to the nucleus where it activates transcription of a number of pro-inflammatory and fibrotic factors. And the idea is that a medication, finerenone in this case, when binding to the receptor, blocks the transcriptional process. And this is just a blow up of what that receptor looks like. I would also remind you that cortisol can also bind this receptor. So while aldosterone may be the primary mediator, there is a role for cortisol activating it as well. And when finerenone, which is a very bulky antagonist, binds the receptor binding site, it also is so bulky that this little pink bar here, which is a transcription activator binding site, is also blocked. So in the non-immune cells, this is very potent in terms of reducing inflammation. This is important because we now have a therapy targeting this pathway that also has delivered. And this was shown in this portfolio of Fidelio and Figaro trials, meta-analyzed together as Fidelity. All the patients who enrolled had diabetic kidney disease, but in Fidelio, they had greater albuminuria and lower GFR, so the kidney endpoints were primary. In Figaro, they mostly had microalbuminuria and preserved GFR, so the cardiovascular endpoints were primary. And then the secondaries were flipped. So in Fidelio, secondaries were cardiovascular, and in Figaro, secondaries were kidney. So the kidney outcome, highly positive again, hazards ratio 0.82. For the cardiovascular outcome, hazards ratio 0.87. And then the meta-analysis. And I would also point out to you that I don't think ever in the history of nephrology, we've enrolled over 13,000 patients in a clinical trial program before. So hooray, we can enroll people on trials. The cardiovascular outcome, again, lined up perfectly with the single study analysis at 0.86. The kidney disease outcome was even lower. And there were comparable risk reductions even in people who were concurrent SGLT2 inhibitor users, again, heralding this idea that combination therapy. So basically on top of SGLT2, they got the benefits from finerenone, that these may be complementary and additive. I'm not going to belabor this, but again, finerenone is not a fire and forget medicine either. Safe prescribing does require monitoring of kidney function and hyperkalemia risk. This is taken directly from the FDA label and is on our recent paper. We made this table to help clinicians with guidance about how to implement therapies. But basically, either for GFR below 60 or potassium over 4.8, you've got to use the lower dose. And this is will be in the slides that can be made available to you, or it's in our paper as a tool that you can use when you prescribe these therapies. I mentioned SGLT2 inhibitor use and efficacy. I'd also like to show you this paper that just came out. Peter Rossing is the first author, where they looked at hyperkalemia events by SGLT2 inhibitor use. And you can see, again, this is post hoc, but a marked reduction in rates of hyperkalemia adverse events. 8% in finerenone users on SGLT2, whereas it was 18 or almost 19% with finerenone and no SGLT2. So, and then they looked at it by different levels of potassium, again, marked mitigation in hyperkalemia risk. So the other really attractive thing about this combination is it might also allow more people to be on finerenone who otherwise couldn't because of hyperkalemia with using a concurrent SGLT2 inhibitor. So this is where we are now. This is the new pyramid that will be published in the next few months from KDIGO. At base, of course, healthy lifestyle is always encouraged, but what's new is on first-line drug therapy, you see SGLT2 inhibitors, and I think this figure is going to be revised to where it says metformin optional now. That's the big change. And then now both GLP-1s and non-steroidal mineralocorticoid antagonists have been added as goal-directed therapies for residual albuminuria and or glycemia, then along with other strategies for glycemic control and cardiovascular risk reduction. However, I'm going to make a few final comments about implementation, because while all this is great, it doesn't matter if the patients don't get the treatments. So this is from our large CURE CKD registry, looking at use of different medications in patients with chronic kidney disease. And this report is from an earlier paper where we looked at in 3-year inclusive, well, they're actually 4 years because they're inclusive years, 6, 7, 8, and 9, for example. Use of different medication classes over these 3-4-year inclusive periods. And while ACE inhibitor and ARB use went up over this time frame, the first guidelines that came out that specifically recommended them in diabetes were 2006, even though the studies were published earlier. We did see an increase in uptake, but notice that overall, even by 2017, this total is only about 15%. And if we look specifically at those who had diabetes with CKD and hypertension, we got up to a whopping 25%, over some 12 years of guideline recommendations. And at the same time, we gave more potential nephrotoxins in the form of non-steroidals and proton pump inhibitors. In fact, we gave more non-steroidals than we did ACEs or ARBs. So we were more likely to do harmful things and less likely to do helpful things in the real world. And this is from both Providence Healthcare, where I work, and UCLA Health. And nobody was doing a good job, and it didn't matter whether it was a community clinic or the academic medical center or safety net hospital. We're just all about in the same boat. So, you may think you're doing okay, but remember, in the nephrology clinic, you might have 80% of your patients on ACEs and ARBs, but most of these people aren't in your clinic. They're out in primary care and other clinics where this is just not on the radar. When we look at use of the newer glucose lowering agents, this just came out showing glucose lowering agents juxtaposed with these various trials that we've discussed on a timeline. SGLT2s are shown here in yellow, and even as recently as into 2020, we're still only at 13% use. GLP-1's a little better, but still not more than 17% use as recently as 2020. So how can we do better? The other thing that we're really promoting in the guidelines is for implementation strategy is multidisciplinary team care. It's important for the workload issue because as we've discussed, there are many, many patients who would benefit and not enough of us to go around. So we really do need to forge strong partnerships in terms of interspecialty collaboration. That's primary care, diabetes, nephrology, cardiology, but also multiple disciplines who can participate in delivering these therapies. We're working very hard, as I mentioned, on harmonizing the clinical practice guidelines, really emphasizing risk mitigation strategies so we implement safely and get clinicians comfortable with prescribing, so that's not a barrier. Multidisciplinary care, so we divide and conquer. For example, the anticoagulation clinics that are run by pharmacists is potentially a model for how we could deliver, especially the glucose lowering therapies and finerenone that do require monitoring. Again, these aren't fire and forget drugs, but where we can work in partnership with pharmacists on protocols that we agree on to help manage these patients. And then importantly, patient self-management, teaching patients how to monitor and manage, not only to reduce risks, such as the Stop DKA protocol, but importantly to be focusing on good glucose and blood pressure control, which they may be able to self-manage, and then multidisciplinary education so that we all are informed and are practicing based on common principles. So I guess I'll just give one quick case presentation and then wrap it up about how we might do this. So this is actually one of my patients, and this is really a move toward, even though we don't yet have biopsies and biomarkers, even now, based on what we know, how we can use clinical phenotyping to individualize therapy. So this is an older woman. She's had problems with recurrent heart failure hospitalization. She's on a classic regimen, loop diuretic, beta blocker, ACE inhibitor, metformin. And she's back at her primary care's physician's office with more dyspnea, not quite ready for admission, but not doing well. She's got RALs and 2+ edema to mid-calf. And the lab shows that she's got mild hyperkalemia. She's got an eGFR of 34, macroalbuminuria. Glycemic control is decent with an A1C of 6.8, and she's got a low ejection fraction on an echocardiogram. So here what we want to personalize is kidney and heart protection. Even though we're nephrologists, remember, heart risk is also very, very important. This is the phenotype of DKD with congestive heart failure. So we would want to add an SGLT2 inhibitor, and it doesn't matter which one. These are the 3 labeled ones with the indication in the US. And remember that the SGLT2 inhibitor may help us lower the serum potassium to where we could introduce an MRA, which would be beneficial for her heart as well as her kidneys. And finerenone is the drug with an indication at this point. And because we're looking at this person holistically, she comes in a whole person, not just a kidney, but also with the heart and with diabetes and other problems. We would also consider that a neprilysin inhibitor ARB, so sacubitril valsartan, could be substituted for the ACE inhibitor. So the take-home points are that we now have an emerging menu of new therapies, SGLT2s, GLP-1s, and a non-steroidal MRA, along with our conventional ACE inhibitors or an ARB that are recommended now as standards of care for persons with diabetes and CKD. And CKD risk assessment and monitoring is really necessary for delivering goal-directed therapies and identifying people who will benefit, and that a multidisciplinary team care approach is really needed to promote implementation and personalizing therapy to optimize kidney and heart protection. My wall of gratitude over the many, many years in this long journey, I've worked with many people, but I do want to call out, since I'm here at Northwestern, my roots here and mentors, Marie Levin, Francesco Del Greco, and Endocrinology, Mark Mullich and Norbert Frankel. I remember them and am very fond of them. So thank you very much.
Thank you so much, Dr. Tuttle, for a really wonderful, fantastic talk, and clarifying so many aspects and providing these fantastic updates in diabetic kidney disease. So I'm going to start with a question that we have here in the Q&A from Dr. James Matthew, who is asking if there is a dose-dependent benefit difference for SGLT2 inhibitors.
No, and that's the beauty of them. It's from that standpoint, it's really easy. We in the clinical trials for kidney disease, all of them have used the lower dose, so 100 of Cana, 10 of DAPA. The IMPA kidney study is ongoing, but it uses 10 of empagliflozin. But the truth is, if you look at those GFR trajectories, and then other studies have looked at the clinical outcomes, it doesn't matter by dose. So it does appear to be largely dose independent.
Excellent. Another question from Dorian Kaminsky, who is asking, commenting first, absolutely inspiring talk. Is there a rationale to replace steroidal MRAs with finerenone to indications like heart failure, ascites in patients with concomitant chronic kidney disease and diabetic kidney disease?
Well, finerenone is the only MRA of any type that has an indication for kidney disease, and it's the only one that did the big outcome trials. So that already puts it in first place. We actually do see less hyperkalemia with finerenone than the traditional MRAs, and this may be because it has a shorter duration of action, and it also seems to have a greater effect on non-epithelial cells. We don't really know why, but that actually turns out to be an important issue from the standpoint of safety, because if there's less effect on epithelial cells, there's less effect on electrolyte transport and hyperkalemia. With regard to heart failure, I would certainly defer to experts in heart failure, but when we look at the cardiovascular outcomes in the Fidelity meta-analysis or either of the trials alone, well, there was a benefit on both ASCVD and heart failure. There was actually a larger benefit on heart failure. And, it's always hard comparing between trials and different populations and study designs. But what we can say is, at least in the population of people who have diabetes and CKD, the heart failure benefit was at least as large as we've seen in other heart failure trials. So I think I wouldn't go outside of the CKD realm to make any recommendations, but within the CKD population, I think finerenone is a good choice for concomitant heart failure, which was one of the reasons I presented that case. And the truth is that, you know, she's a very typical person. They don't often come in with just one single comorbidity. So she has heart failure, CKD, mild hyperkalemia. So she's really an ideal patient to really consider concomitant SGLT2 and finerenone.
Dr. Tuttle, I think you're okay. Yeah, we got a little bit of freezing, but we are good now. So I have a question about the emerging guidelines that you showed. And so in patients with diabetic kidney disease, it seems that SGLT2 inhibitors will show up as first-line agents, you know, with metformin, and metformin will be optional. And I absolutely love SGLT2 inhibitors, but I have grown with this metformin, and I'm wondering, you know, in terms of the diabetic management, do you think that that will be, so SGLT2 inhibitors will be equally well for glycemic management? And what about this hyperglucagonemia that, you know, sometimes our endocrinology colleagues, you know, complain of?
Right. Well, I think that for glycemic control, if the GFR is adequate, most people would use metformin with SGLT2. It's really saying, though, that in somebody who needs SGLT2 for organ protection, either heart or kidney, if that's sufficient to lower their glucose, then they may not need metformin. And then you would put SGLT2 in first place because of the organ protection and the side effect of glucose lowering. But many people will need more than that, in which case metformin would be first line, at least to a GFR of 30. And then the mild hyperglucagonemia, that's an interesting, really interesting question. So, you know, we believe it's at least partly responsible for the mild ketosis, which in a mild form may be beneficial in terms of myocardial function because of beta hydroxybutyrate as fuel. It really becomes a problem, though, when it transitions to a full-blown clinically relevant ketosis. The people at highest risk for that are people on insulin, which is why I really stress the importance of, if we have to reduce other glucose-lowering agents, to introduce an SGLT2 to maintain at least low-dose insulin, because that's our best defense against ketosis. That in non-insulin users, it's really pretty rare. And there's at least a signal that, and this may be a good thing about low GFR, that ketosis seems to be less common in people with lower GFR, but that's based on all post-hoc observations. So, you know, take it with a word of caution. But I think the most important thing is patient education, monitoring, and maintaining insulin. Now, type 1 diabetes is a totally different situation. And the reason we haven't had an SGLT2 inhibitor trial has been this great angst over the safety. But for type 2, I think that for the most part, as long as we maintain insulin, we can really mitigate the risk of ketosis.
That's excellent, excellent point. So we have a question from Mr. Davis, who is, saying, thank you for this interesting talk. What are your thoughts on why the uptake on new treatments has not been faster?
Well, okay, so I will just give you my opinion on that. I think it's an area that needs study, but for one, I think that part of the problem, like with the ACEs and ARBs, I think that's our best use case, because, you know, we've known that those were indicated therapies for, you know, arguably 2 decades. Is I think, remember that most of the people are not being treated by nephrologists. And one, kidney disease is not on the radar for a lot of people in primary care. We know that because if you look at the screening, the albuminuria screening, annual albuminuria screening, people with diabetes, depending on the data set you want to look at, doesn't even get to 50%. It's 10 to 40%. So if we aren't even identifying the patients, we're not going to treat them. And then even among those who are identified, I think there are a lot of fears of side effects like hyperkalemia, like AKI. And then the other thing that we've seen, and actually Glenn Chertow's group published on this, that when people are admitted to the hospital, ACEs and ARBs are usually stopped and they're not restarted. So sometimes it's because they get medicine stopped and then nobody remembers to restart it. So we've had a very disorganized system of care. We need better education of our colleagues who are actually treating most of the patients. We need engagement of those people and healthcare systems to emphasize that this is important care and support it. And we need better screening and detection so that we actually know who we're supposed to treat.
Definitely. So I will move with the next question from Dr. Srivastava, who is asking regarding barriers. Cost is always an issue with new medications. So how do you position these aspects with patients to get their buy-in?
So with the SGLT2s and the GLP-1s and finerenone, cost is a big barrier. So SGLT2s and finerenone, depending on insurance coverage, are typically $500 to $800 a month out of pocket, unless people have really good insurance. I've seen a few people who've had copays that are about $100. But if you actually look at pharmacy websites for prices, that's it. And GLP-1s are even more expensive, $800 to $1,200 a month. So that is a huge issue, is drug pricing. But that's a big issue for the United States across all therapeutic areas. And it has to be addressed because if people can't afford the medicine, they're not going to get it either. There have been some cost effectiveness analyses showing that in DKD, the cost of a quality adjusted life year for empagliflozin is $25,000, and the willingness to pay threshold for most therapies is $100,000. So they already meet the quality-based criteria for willingness to pay by insurance companies, but I don't think insurance companies have really got their heads around that yet. And if the cost of the drugs went down, it would go down even more. The part of the problem too is that when we look at the expensive outcomes in kidney disease, they're way down the road from when we start treatment. And insurance companies don't have a long-term time horizon because people change insurance, and so they're not so interested in reducing costs from 5 years from now as they are next year. So those are all issues for our health policy and healthcare systems and insurance companies to address. And through the DKD Collaborative, which was initiated and initially led by Dr. Quaggan, we are working very hard with our policy colleagues at ASN and putting together a policy action plan. And hopefully we have a paper under review at JASN that we hope will be published that takes these issues head on, because even though the science is a lot more interesting to many of us and it's super fun to initiate these therapies, if this work isn't done, none of that even matters.
Absolutely right. So the next question that we have is from Dr. Bhatia. Great talk, Katherine. We may never know if there are truly synergistic effects and if combination therapy is always needed. What are your thoughts about this? Start all meds at one time? What will be the steps?
Yeah, great question. I will say that there is a trial starting now of finerenone with or without SGLT2. So that's the first combination study. There is also a study, Zenith, that's testing an endothelin antagonist with SGLT2. And there's one small study looking at an albuminuria outcome of empagliflozin with semaglutide. So we are moving in the direction of doing some of the studies. We don't have the data yet. However, the signals are that they're more likely to be complementary and may even mitigate each other's side effects, like the hyperkalemia mitigation of hyperkalemia with an MRA by an SGLT2. So it's a really good question because we have, analogous to our heart failure colleagues now, we have 4 pillars of therapy, right? We have an ACE or an ARB, we have SGLT2, we have an MRA, and we have GLP-1 receptor agonists. I think that not everybody's going to need all of those therapies. And that's where I presented the case where I think you would want to try to individualize that patient's needs and risks to identify best therapies. That said, I don't think anybody knows about what the sequence should be or the timing. And I would also point out that, our standard of care is really evolved based on when drugs were approved, not biology. So, if we leveled the playing field, you could ask the question, will we really start an ACE or an ARB first? And that's an open question. But I think now, to get to Dr. Battier's question, I think we would start an ACE inhibitor or an ARB. I think because of the GFR changes, not that I'm that worried about them, but I think a lot of clinicians would be. I would stage that. And, most of the trials required at least 4 weeks of stability on an ACE or an ARB before introducing the SGLT2. So I think we could follow that. But I would add an SGLT2 to an ACE or an ARB, and would like to see them stable on therapies that abruptly affect GFR for at least 4 weeks. So then, you could make the case then, if you add the SGLT2, then I'd like to see them on therapy for, at least 4 weeks. And then if they have persistent albuminuria, that, at least in the guidelines, it's a practice point because we don't have trials, but what we said was that it would be reasonable to add finerenone for persistent albuminuria after the trial of an ACE or an ARB with SGLT2. I hope that answers the question.
Yeah, that's excellent response. So we have another question about the timing of the SGLT2 inhibition in AKI. Could initiation of SGLT2 after AKI be protective and mitigate the risk of progression to CKD?
I think that's a really good question. We know that the agents actually reduce risk of AKI, but the question would be, if you have someone in the hospital, they've had an AKI event, would you add SGLT2, let's say at discharge? The answer to that question is going to be opinion-based, and people might have different opinions. My opinion would be, if that person has recovered from the AKI and they have stable GFR at the time of discharge, I think that is a moment of opportunity. The important thing, though, would be, remember, they're not fire and forget medicines. Is if you do that, you want to see that patient again soon, a post-discharge clinic within the first week or two, and recheck volume status, blood pressure, electrolytes, and GFR.
Definitely. And I think it's a great opportunity to add Dr. Quaggen's question, very relevant, whether we should be starting these therapies in hospitalized patients like our cardiology colleagues, at least in selected patients.
I agree. Yeah, our heart failure discharge orders, I'm sure you have them there, people have all these things are standardized now. It's on the list of therapies, along with all of the other 4 pillars for heart failure. So I think that's part of activating, our kidney disease protocols, and coming out of the nephrology silo and being more mainstream, because in the hospital, a lot of those people are not going to be on your service. They're going to be on a medicine service. Is not just be the, the consultant, but really engage with the treating teams, and as a major training program, training your interns and residents to think this way, and that hospitalization is a moment of opportunity. And if there's not a contraindication and they're stable, maybe even having some standardized orders, an ACE or an ARB plus an SGLT2 for people with diabetes and CKD, and then appropriate follow-up, not fire and forget.
Definitely engagement, the key factor here. Well, Dr. Tuttle, thank you so much for a fabulous talk and answering all these questions and having a great discussion. So, before we basically, leave this event, I just want to remind, our audience to take the time to hopefully complete a Zoom poll after the session to provide us some feedback, which will help us to improve our webinars. That will open when you leave the webinar. And also tomorrow is the World Kidney Day. So sorted to kidney disease, remember to take, pictures with your favorite socks and, tweet them. Just basically, to raise our voice for the 850 million patients suffering from kidney disease. Thank you again. Have a wonderful day, everyone.
Thank you.